Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Director at the New York Presbyterian Hospital in New York City, and welcome to Sound Bites. Today we're going to go over the tale of two pregnancies, part 1. Now today's case involves a 22-year-old female who was presenting to the emergency department complaining of lower abdominal pain and vaginal bleeding for the last day. Now her pertinent history was that she was a G1-P1 with a last menstrual period of approximately 7 weeks prior. So based on her presenting history, we went ahead and ordered a urine pregnancy test which came back positive. So our first move was to get her into the GYN room to perform a GYN exam and also a bedside ultrasound. So bedside OB/GYN ultrasound was one of the very first indications for ED ultrasonography and one that remains very useful on a day-to-day basis. So let's go through some slides in terms of what we're actually looking for on the ultrasound and how we can rule in an intrauterine pregnancy and conversely rule out an ectopic pregnancy. One of the overriding reasons for the origin of emergency OB/GYN ultrasound is the fact that ectopic pregnancy is the leading cause of first trimester maternal mortality. And unfortunately for us, ectopic pregnancy has become more common in the emergency department due to increasing numbers of our patients who are on fertility treatments. Luckily for us, bedside ultrasound has developed as a reliable means to evaluate pregnant patients for ectopic pregnancy. As emergency physicians, what are the goals of emergency OB/GYN ultrasound? Well, first of all, we're hopefully going to detect an intrauterine pregnancy. Detection of an intrauterine pregnancy, in the vast majority of cases, will help us to exclude an ectopic pregnancy. However, we may be able to detect an ectopic pregnancy by visualization of the actual ectopic, but many times we're not going to be able to see the actual ectopic pregnancy, and all we're going to be able to see is detection of ultrasound findings that are suggestive of ectopic pregnancy, such as an empty uterus or free fluid in the pelvis or abdomen. So a golden rule of emergency medicine is that in all female patients presenting to the ED complaining of abdominal pain, vaginal bleeding, and/or shock, we must assume ectopic pregnancy until ruled out by pregnancy testing and/or ultrasonography. So returning to the case that I discussed in the intro segment of this module, our patient was presenting with vaginal bleeding in pregnancy. So the main categories that we're thinking when we see a patient who's having bleeding in the first trimester of pregnancy is number 1, does our patient have a threatened abortion, which is identified as the presence of an intrauterine pregnancy with vaginal bleeding. The second main category of vaginal bleeding in pregnancy is an abnormal pregnancy that is classified as a few different terms: incomplete abortion, a missed abortion, blighted ovum, or fetal demise. All these signify the presence of fetal membranes or parts without the expected fetal growth or cardiac activity. Now our patient may also be having a completed abortion, defined as the lack of a presence of an intrauterine pregnancy. Usually at that point the cervical os will be closed. And the last and most dangerous category of vaginal bleeding in pregnancy is ectopic pregnancy. When faced with a patient who's bleeding and pregnant, here's a good strategy for OB ultrasound. Generally, we want to begin with a transabdominal approach, which gives us a larger view of the pelvis. We can look for fluid within the pelvis, the suprapubic view. We can also move the probe up into the right upper quadrant area to look for free fluid around the liver and the kidney. We may be able to adequately view an intrauterine pregnancy on the transabdominal sonogram, thus closing the case. However, if an intrauterine pregnancy is not visualized on transabdominal sonography, we need to follow with a transvaginal scan. The size of the bladder is very important for transvaginal sonography. It's important to have the patient void completely before performing the transvaginal scan, as a full bladder pushes the uterus into retroflexion, making it harder to see on transvaginal sonography. Now let's take a moment to review some of the OB/GYN anatomy that we need to know to perform OB/GYN ultrasonography. As we see here, we have an illustration showing the uterus to the left and the adnexal structures to the right. Note the areas of the uterus, the lower cervix, the intermediate body, and the upper fundal region. Now we define the fundal region as the area where an intrauterine pregnancy will be located. Notice the area where the fallopian tube joins into the uterus, defined as the interstitial region in a normal uterus, and the corneal region in a bicornuate uterus. We also appreciate the areas of the fallopian tube, the proximal isthmal region, the intermediate ampullary region, which comprises the majority of the fallopian tube, and the distal infundibular region. Here we see the broad ligament that encases the fallopian tube and the ovary, and notice the ovary located adjacent to the infundibular region of the fallopian tube. Here's a slide showing the sequential appearance of structures in pregnancy and the time that we can see on both transvaginal and transabdominal sonography. As we see in the column to the left, the very first structure that we'll see is a gestational sac appearing at about 4.5 weeks on transvaginal sonography. Now, for our purposes, we want to see a yolk sac inside a gestational sac, as we'll talk about later, and that appears at about 5 to 5.5 weeks on transvaginal sonography. Notice that the same structures come into view about a week later on transabdominal sonography. Notice that the fetal pole is seen at about 5.5 to 6 weeks on transvaginal sonography and about a week later on transabdominal sonography. And the fetal heartbeat is seen at about 6 weeks on transvaginal sonography and about 7 weeks on transabdominal sonography. Another important concept for the performance of OBGYN sonography is the correlation of the serum beta-HCG to the ultrasound findings on a normal pregnancy. As we can see on the transvaginal sonogram, it takes about a level of 1500 to 2000 on the beta to show an intrauterine pregnancy, defined as the presence of a gestational sac. On transabdominal sonography, we see a higher level at about 6,500. Now, that rule does not apply to ectopic pregnancies, which can secrete beta-HCG at atypical levels and are commonly seen with levels less than 1,000. Here's the first structure seen with an intrauterine pregnancy, and that is a gestational sac. While the gestational sac is commonly referred to as the first sign of a pregnancy, it's not diagnostic for an intrauterine pregnancy in the hands of an ED sonographer. And that is because a small gestational sac can be seen as a pseudogestational sac of ectopic pregnancy as a result of hormonal stimulation. So a general rule of emergency ultrasound is that visualization of a gestational sac is not adequate to call an intrauterine pregnancy. To the right, we see a still image, a sonogram showing a small gestational sac within the fundal region of the uterus, and below that we see an actual gestational sac that came out of a patient. Notice it has a transparent membrane-like type appearance. Here's video showing a gestational sac in the long axis configuration to the left and short axis to the right. Notice that the gestational sac has a rounded, hypoechoic or darker type appearance as seen within the fundal region of the uterus in both the long axis configuration to the left and short axis to the right. Now remember that the gestational sac is seen at about 4.5 to 5 weeks on transvaginal sonography and about 1 week later on transabdominal sonography. Another early sign of pregnancy that's commonly referred to by OBGYN is the double decidual sign. This occurs as a result of thickening of the endometrial decidual layer with separation of the layers, splitting the inner layer, the decidua capsularis, from the outer layer known as the decidua vera. However, the bottom line is that the presence of the double decidual sign is suggestive of an intrauterine pregnancy, but not diagnostic in the hands of an emergency physician performing sonography. Here's what the double decidual sign looks like on bedside sonography. What we see here is in the middle we see a larger gestational sac, that hypoechoic or dark area located within the uterus, and we see here thickening of the decidua surrounding the gestational sac. Notice the inner layer, that inner white circle, known as the decidua capsularis, and notice that it's split from the outer layer, the decidua vera, by a little dark line, a little dark circle that surrounds the capsularis and separates it from the outer white circle, the decidua vera. Here's a sonographic finding that we define as pathognomonic for an intrauterine pregnancy, and that is a positive Cheerio sign that is made up of a gestational sac with an inner yolk sac within the gestational sac, and the yolk sac has the appearance of a circle or a Cheerio within the larger gestational sac. Now, the presence of a fetal pole with a heartbeat is bonus confirmation of an intrauterine pregnancy, but for emergency physician sonographers, a yolk sac within a gestational sac is diagnostic of an IUP. And here we see the image to the right in which we see the gestational sac, and inside we see the positive Cheerio or the yolk sac inside the gestational sac. Here's a video clip showing a definitive intrauterine pregnancy as shown as a yolk sac inside a gestational sac. Here we see the uterus, and notice that inside the uterus we see a relatively large gestational sac, that hypoechoic or darker area, and inside the gestational sac we see the circular yolk sac or the Cheerio. So in this patient, we can make the diagnosis of an intrauterine pregnancy and effectively rule out an ectopic pregnancy. Now recall that a yolk sac is seen on transvaginal sonography at about 5 to 5.5 weeks and about a week later on transabdominal sonography. Here's a little further developed pregnancy. Now we see a larger gestational sac, the darker area within the fundal region of the uterus in this patient, and we see again to the left of the gestational sac the circular chireo or the yolk sac, and let's look just to the left of the yolk sac, and what we see here is a tiny fetal pole. Interestingly, as we applied zoom and magnified the fetal pole, we're able to pick up the presence of a tiny heartbeat. Now the fetal pole is seen at about 5.5 to 6 weeks on transvaginal sonography and about a week later on transabdominal sonography. Here we see the transvaginal short axis view of a little further advanced pregnancy. Right is located over towards the indicator dot. We see the large gestational sac, and within the gestational sac we can see the chireo or yolk sac to the superior aspect of the gestational sac, and right below the yolk sac we make out the fetal pole. And note within the fetal pole we can see the flicker of cardiac activity. So this is roughly a 7-week intrauterine pregnancy on transvaginal sonography. Note also the good amount of myometrial mantle around the pregnancy, signifying that this pregnancy is in a fundal location. Here's an intrauterine pregnancy on transabdominal sonography, making the point that many times on transabdominal sonography we can actually diagnose a intrauterine pregnancy and we don't have to proceed to a transvaginal sonogram. Recall that a full bladder is optimal acoustic window onto the pelvis in a transabdominal sonography orientation. Here we see the larger gestational sac, the darker sac, that contains the yolk sac as seen here to the inferior aspect of the gestational sac. And superior and to the left to the yolk sac, we actually see the fetal pole. Notice that within the fetal pole we can see the flicker of a heartbeat. So based on this transabdominal sonogram, we can make effectively the diagnosis of an intrauterine pregnancy and effectively rule out ectopic. Here's an interesting sonogram in which we had a patient who presented pregnant with vaginal spotting. As we look on transvaginal sonography, what we see here is the presence of 2 gestational sacs side by side. And within each gestational sac, we can see the circular chireo or yolk sac and tiny little fetal poles adjacent to the yolk sacs. So here we're able to make the diagnosis of a dichorionic twin pregnancy, dichorionic referring to 2 gestational sacs. Here's a bit more advanced twin pregnancy. Again, we see the presence of 2 gestational sacs. Notice the larger fetal poles present within both of the gestational sacs. And remember that fetal heart activity is seen at about 6 weeks on transvaginal sonography and about a week later on transabdominal sonography. Interestingly enough, many times when we see twin pregnancies, there's a dominant twin, and we see the superior twin is much larger in size on the fetal pole than the smaller inferior located twin. Here's an intrauterine pregnancy in a retroflexed uterus. Notice that in retroflexion, the cervix is located anteriorly towards the top of the screen and the uterine fundus curves backwards posteriorly away from the cervix. Within the uterine fundus, we can see the larger gestational sac, and notice within the gestational sac, we can see the positive chireo sign or the yolk sac. And actually, as we scan through the gestational sac, we could actually see the fetal pole and the heartbeat. So the signature of an intrauterine pregnancy, in this case a retroflexed uterus. Here's a further developed pregnancy, in this case a 2nd trimester baby, and we can see a positive fetal heartbeat. Let's look at the baby's right hand, and we can see the thumb is securely located in the baby's mouth, and it's very common to see the babies sucking their thumb in utero. So this defines an intrauterine pregnancy, ruling out an ectopic pregnancy in the vast majority of patients. Here's another video clip from a 2nd trimester pregnancy. Notice the presence here of 2 babies signifying twin pregnancy. Again, we see a membrane going in between the 2, making the fact that this is dichorionic or 2 twins within separate gestational sacs. And we can see the babies moving around performing their twin IUP gymnastics. Here's video from a 2nd trimester pregnancy that I like to call the next Oscar de la Hoya. Notice the fancy hand and footwork going on. We also note a rim of uterus surrounding the pregnancy, confirming an intrauterine pregnancy, and this is important as even in 2nd trimester pregnancies we should look for that rim of uterus to differentiate from a type of ectopic pregnancy that can be seen in a peritoneal or abdominal location. Here's another early second trimester pregnancy, and as I work in northern Manhattan, I like to refer to this as the merengue baby. Notice the baby dancing around to the merengue beat within the amniotic cavity. Let's now turn to one of the important goals of OBGYN sonography, and that is dating of fetal gestational age. In the first trimester, we'll assess gestational age by measuring the crown rump length. This is considered one of the most accurate indicators of the gestational age, as growth curves can vary during later pregnancy. In the second trimester, we'll assess skull biparietal diameter to measure the gestational age. In the third trimester, the gestational age will be measured by a biophysical profile, including the measurement of femur length. Here's a first trimester pregnancy, and we're going to assess the gestational age by measuring the crown rump length. We see the fetal pole stretched out within the gestational sac, and we have the calipers placed, measuring across the total fetal pole. We see the crown over towards the right and the rump over towards the left. We see the calipers in between the two, and we have an assessment of the length of the fetal pole, which is 1.46 centimeters. Now, if we plug this into the software package on the ultrasound machine, we'll get the gestational age, and as we can see here down towards the lower left, it comes out at 7 weeks, 6 days. This would be a nice image to print out and give to your patient to take to their visit for their follow-up with their OBGYN to assess the growth of the pregnancy. In the second trimester, we're going to turn to a different form of dating. We're going to look at the measurement of the skull circumference, known as the biparietal diameter. Here we can see a measurement of the skull, and we want to measure biparietal diameter by looking at an axial cut through the skull at about the level of the thalamus. We want to measure from outer table of the skull table proximally to the inner table distally, and we can see the calipers down across the skull, giving us a measurement as shown to the lower left of 3.26 centimeters. Once we plug this into the ultrasound machine software, it'll give us a calculation of 16 weeks, 1 day. Following a determination of gestational age, the next goal in assessment of pregnancy is measurement of fetal heart rate. Now, the normal fetal heart rate ranges from 120 to 160 beats per minute. However, low rates down to 90 beats per minute can be seen in early pregnancy. The preferred method of determining fetal heart rate is now the M-mode Doppler. Power Doppler, while used in the past, imparts more ultrasonic energy to the developing heart. M-mode gives less energy and less heating to the heart, and thus may be better for the developing fetus. Here's a video clip showing measurement of the heart rate using M-mode. Notice that we have the baby zoomed up to the top, and we're placing the caliper of the M-mode directly over the baby's heart. We see a wave-like pattern showing motion on M-mode, and this particular ultrasound machine would measure every other peak, giving us a heart rate of 180 beats per minute. So M-mode sonography, an excellent way of documenting motion of the fetal heart rate and allowing you to print out something to put in the chart to show that the embryo or fetus had a heartbeat at the time that you examined the patient. Here's power Doppler of the embryo's heart, and this was the former way that we would document fetal heart rate activity. However, keeping the power Doppler onto the developing heart may cause unnecessary heating of the heart valves and other developing structures of the heart. For that reason, M-mode has now become the predominant way of measuring fetal heart activity across the country. While the great majority of pregnancies will have a successful outcome, we should be able to recognize some of the signature findings of an abnormal pregnancy, like fetal demise. Abnormal pregnancy or fetal demise is going to be seen in a pregnancy where you have a larger gestational sac defined as greater than 10 millimeters or a centimeter if no yolk sac is seen. If the gestational sac is greater than 18 millimeters, this is going to be abnormal if no fetal pole is seen. And many times in an abnormal pregnancy, the gestational sac will have an irregular shape with a scallop type appearance. Here's a video clip showing fetal demise or an abnormal pregnancy, and we see a very large and irregular gestational sac. What we also see is the presence of subchorionic hemorrhage. It's that dark area of fluid outside the gestational sac, below the chorion. We can also see a little layer of gas towards the top area, showing reverberation artifact towards the top of the video clip. Here, the gestational sac is much greater than 10 millimeters, and we don't see a yolk sac. So we're able to diagnose an abnormal pregnancy or fetal demise. Here's a still image of the same patient, and we're putting the calipers down to measure the diameter of the gestational sac. Notice that it measures out at 2.78 centimeters by 1.67 centimeters, a very large gestational sac greater than the 1 centimeter dimensions that without a yolk sac define an abnormal pregnancy or fetal demise. Here's another video clip from an abnormal pregnancy. Here we see an irregular and large gestational sac. Within the gestational sac, we see a large oval structure, which is actually the large amnion. Notice that we fail to see a fetal pole. And the measurements of this gestational sac are much greater than the 18 millimeters that we defined as being abnormal in the absence of a fetal pole. Other numbers that are commonly used to define an abnormal pregnancy or fetal demise is if the gestation is greater than 7 weeks, the pregnancy is abnormal if no fetal heartbeat is seen. We can measure the fetal pole, and if the fetal pole is greater than 5 millimeters in dimension, it's also an abnormal pregnancy if no fetal heartbeat is seen. Here's a video clip showing an abnormal pregnancy. What we see here is an irregular gestational sac, a very large circular amnion, and within that we see a small embryo. Notice that we fail to appreciate any presence of a fetal heartbeat as we scan back and forth through the embryo. So very unfortunately, this was an abnormal pregnancy with fetal demise. Another form of abnormal pregnancy that you may see in the emergency department as you start to perform more and more OBGYN sonography is a molar pregnancy. This occurs as a result of gestational trophoblastic disease and is a spectrum of disease from a benign hydatidiform mole to invasive choriocarcinoma. The majority of molar pregnancies are derived only from paternal chromosomes. There is no maternal chromosomes in the embryo. And the ultrasound appearance of a molar pregnancy will look like a cyst-like bunch of grapes with a snowstorm appearance. Classically, the serum beta-HCG is very elevated in a molar pregnancy. Here's a video clip of a molar pregnancy, and what we see here as we scan back and forth through the uterus is the absence of a gestational sac or intrauterine pregnancy, but we see here is a cyst-like, grape-like bunch of structures there within the fundal region of the uterus, defining a molar-type pregnancy. Once an abnormal pregnancy is diagnosed in the emergency department, it's important to follow it up with a formal ultrasound and OBGYN consultation for further evaluation and treatment. So now that we've gone through a few more slides giving you some more information about OBGYN ultrasound, let's return to our patient and review the findings that we actually found in this case. Here's a transvaginal sonogram that we obtained from our patient. Notice here we see the presence of an outer uterus, and inside the uterus we see a large gestational sac. Inside the gestational sac we see the superior yolk sac, the Cheerio sign, right above the fetal pole, which we can see stretched out below the yolk sac. Notice the presence of fetal heart activity within the fetal pole, and we can also see the amnion billowing out from the fetal pole. Eventually, the amnion will plaster down across the gestational sac to form the amniotic cavity. Thus, this defines a threatened abortion. As we talked about, a threatened abortion is defined as the presence of an intrauterine pregnancy with vaginal bleeding. So what are some numbers that we can tell our patients with regard to their outcomes? Well, in women aged less than 36 with no history of spontaneous abortion, the identification of a positive intrauterine pregnancy with fetal heart activity carries a relatively good prognosis with a pregnancy loss rate less than 5%. However, in women aged greater than 36 who have a history of spontaneous abortions, the risk of pregnancy loss is much higher at 20 to 30%. This study comes from a clinical review in British Medical Journal 2004. There are some sonographic predictors that we can use to determine if our patient is going to go on to a spontaneous abortion. One of these is subchorionic hemorrhage. We see here a pregnancy with a yolk sac and a gestational sac, but note around the gestational sac we see a dark rim of fluid that is a subchorionic hemorrhage. As a percentage of subchorionic hemorrhage increases to numbers greater than 75 to 80%, there's an increased likelihood that the threatened abortion will turn into an actual spontaneous miscarriage. So in conclusion, the diagnosis in this case was threatened abortion, and given our patient's relatively young age and the fact that she had not had a spontaneous abortion in the past, the likelihood that she was going to continue on with a successful pregnancy in this case was very high. So in this case, we were actually able to reassure her, and that made all the difference for her in that visit to the emergency department. So I think this case really shows the benefit of bedside ED ultrasonography when used in the pregnant patient, and how it can really allow you to come to a more accurate and successful conclusion of the case much more rapidly than if you had to order the official scan and wait the several hours that it can take to actually get the scan interpreted and read. So I hope this has been helpful for you, and let's return with the tale of pregnancy part 2.